All right. Good afternoon, everyone. And on behalf of Mountain Pacific Quality Health, welcome to part 3 of our Gradual Dose Reduction Lessons from the Field series. We had initially thought we would do a 2-part series, and we had received such positive feedback and such engagement. We thought, let's look at a part 3. So today, for part 3, we are going to look at a pharmacist partnership in minimizing behaviors and side effects of antipsychotic use. Next slide. My name is Jessie Kinsey. I'm an RN as well as an account manager with Mountain Pacific Quality Health. I'm joining you today from Lewistown, Montana, and I am pleased to have our guest speaker return. He is a pharmacist joining us from Innis, Montana. David Lawless, he manages about 25 clinical pharmacists throughout multiple states, including Montana, Wyoming, Oklahoma, Utah, Arizona, and Colorado. He brings over 25 years of experience in the long-term care setting, specializing in behavioral management. Next slide, please. The objectives for today, as I mentioned, this is a continuation of our prior 2 presentations. We're going to look at the goals of the gradual dose reduction, or GDR, behavior management alternatives, side effect monitoring, and ultimately and importantly, pharmacist partnership in all of the above. And we're going to take a unique approach as compared to our first 2 editions, and take a moment to look at these at some scenarios and kind of offer up some engagement and conversation. Next slide, please. So I guess as we kind of kick things off today, I want to take a moment and chat. So I wanted to ask a couple questions of the audience. So the first question, what interested you most in this series? And if you want to pop that into chat or take yourself off of mute, if you're calling in, you can actually unmute yourself by selecting *6. Feel free to do that if that's more convenient. But if you wanted to take just a few moments, again, what interested you most in this series, if you wouldn't mind replying, and secondarily, what challenges are you seeing? I'll open up.
I'm going to pop on video here for a second and say hello to everybody. Hello, everybody. Yeah. So part of what Jessie and I had talked about, and thanks for having me back. Part of what Jessie and I had talked about is, with COVID and all the restrictions on facilities and so on and so forth, a lot of people have been on these types of meetings, and I think you learn a lot more about asking questions and having kind of a more of a discussion than a presentation. So we're really trying to engage you guys to ask questions and be part of this discussion. We're basically going to have a couple cases, things that one is an actual case that I had in the past, and one is a case that I just made up, but definitely relevant and something I see all the time, but just kind of giving you some ideas. So we're just trying to see which way will be the best way for people to, kind of respond to us as we're asking questions. So feel free to unmute yourself and practice that if you feel like you want to chat and ask questions today, or you can feel free and throw it in the chat. We can do either way. We're just trying to find out what the easiest way for everybody will be.
Thanks, Dave. And it looks like we have some comments in the chat already. Sounds like some challenges from some folks, timing of the GDRs. Another comment, collaborative learning is very effective. So yes, we hope that this is a valuable session for you today. And Tim says, finding what other people are successfully doing when the way you get surveyed can be so different. Yes.
I would love to hear what the situation was with that. Yeah, and that one's a good one. The resistance from some nurses to GDRs due to safety concerns and for staff and other residents. That's a good one. Well, Timothy, I don't know what state you're in, but you can certainly reach out to me directly. I'd love to chat with you. Is it okay if I give people my email on here, or is that against the rules?
Absolutely, go for it.
Okay, I'm going to type my email address in the chat box. So anybody wants to reach out after this with any questions, or I'd love to share that, talk to you about that, Tim, for sure. So it looks like the chat box was going to be the easiest way to communicate, I think, Jesse. So
okay, sounds good. Sounds good. With that, Mary, we have a quick polling question I'm going to pop up there for you guys too. So just taking a little temperature check here. Question to the group: how strong a role does your pharmacist play in your community? Part of our IDT without a question. I only talk to them when they visit our building. And C, I'm not sure their name.
can't wait to see the answers to this one.
Thank you guys for participating. And it looks like we still have some folks admitting from the waiting room too. Again, I'll give you guys just a few more seconds. Some more answers coming in for the polling question. How strong a role does your pharmacist play in your community? All right, it looks like the responses slowed down a little bit. Okay, so here's our results. It looks like 52% of you answered part of the pharmacist is part of our IDT without question. 44% of you typically only talk to them when they visit your community, and a small percent, about 4%, not really familiar with your consultant pharmacist. Thank you guys for participating in that. And let's see if I can populate that for you. There we go. Okay. All right, so with that, Dave, I will pass the floor to you.
Sure. And, I wanted to comment on that just for a second, because that's actually a pretty interesting result. One of the regulations with the pharmacy review is that a pharmacist is supposed to be part of the interdisciplinary team. And, the goal for the pharmacist, and I teach this to my pharmacists all the time, is our goal really isn't to come in and do a review and find all the problems. The goal is for us to work with the interdisciplinary team to create policies and procedures to eliminate irregularities. And then really we should be doing kind of a spot check when we're doing the reviews. So really, hopefully you guys can, after this conversation, you'll have a little bit more of an understanding from my standpoint why it's so important to include your pharmacist. And if you don't feel like you're getting good support from your pharmacist, then you need to talk to whoever's providing the consultant pharmacist and tell them kind of what you expect, because everybody should be getting the same level of service from your clinical pharmacist. So what we did today, and I think the chat's going to be the easiest way to engage everybody, but I'm going to kind of ask questions as we go through and really talk more about case studies and looking at common issues. So scenario one this is actually a case that I had in a facility, and it was really interesting to see kind of what happened in this case. And there's a couple things that I'm going to tease out of this, but the question that I got when I came to the facility is they said, hey, could you take a look at so-and-so? She's really resistant to cares and striking out and confused. And we'd like you to take a look and see if we can increase her Haldol. So that was the original question that I was posed from the facility. So Go to the next slide and we'll talk a little bit about the overall diagnoses that she had. She did have chronic heart failure. She did have some depression. They labeled her with dementia with behaviors. She had restless leg syndrome, anxiety. She had some weight loss and hypertension, and she had meds associated with each of those. 83 years old, had been in the facility for a while. And go ahead and go to the next slide. So this is her medication list. And while the diagnoses may not have been exactly correct, it kind of leads you to what the medications were being used for. So I want to ask just on the outset, you know, we see some meds for hypertension and CHF. We see a couple meds that, you know, are there for depression. They're using Remeron as kind of a weight loss type thing, trying to stimulate appetite. A couple meds for anxiety, a couple meds for the behavior type issues, and really a lot of different medications on board. But does anybody in here see anything that would like stand out to you that you would question? And let's say that Seroquel and Ativan Pura, good. So, and let's assume that we had the GDR letters in place, and you know there's no issue with tapering or what have you. The Digoxin Dose, good one. Lots of psychoactive drugs, Haldol, Seroquel, yep. So again, you know, when they reached out to the physician, good, addressing any pain issues, that's a good one too. When they reached out to the physician, they said, hey doc, this person is having a lot of behaviors. And they said she's on Haldol 0.5 BID. They didn't really include the rest of the medications. They didn't really look at the whole resident. And that's one of the things that I want to kind of make sure that I reinforce with this program and the discussion is that when you have any sort of issue, whether it be falls or behavioral issues or whatever it may be, you never want to, looks like there's a couple people in the waiting room. You never want to just forward over medications for the behaviors. You want to forward over the entire profile. And that's where your pharmacist can really help you in taking a look at the medications as a whole. And I love it because somebody already picked out one of the, Kelly, I bet you are a dietitian. Are you a dietitian? I'm guessing.
Nope, I'm a physical therapist and an administrator.
Oh, good. Well, you've got some great questions too. We will say that the food, appetizers, and preferences were addressed. I don't know much about diets, but my wife is a dietitian. I should have looped her in as well. But they were doing supplements and a couple different things to try and augment the weight loss. Somebody did bring out a really good question, and I'm sorry if I pronounce your name wrong, but Delete Chandler Brown kind of nailed it right on the head, which is the Digoxin Dose. So she does have CHF, and we used to use CHF quite a bit with heart failure. We don't really use it that much anymore. We're really more focused on Digoxin as a rate control for AFib. And the interesting thing in this situation is this particular resident, I had asked for a Digoxin level for a couple different months, and the physician didn't respond to it. And then the third month that I came back, this was actually the month that they had asked me if I would, consult for an increase in the Haldol dose. I got in the chart, and this was before the days of PCC. I got in the chart and I noticed they had done a Digoxin level. They got it back. The dose was the level was toxic. It was 2.7. The normal range is 0.5 to 2. And they had just filed it in the chart. The physician hadn't even seen it. So 2 times I had asked for a digoxin level and the physician didn't respond. And once they finally got the level, it was toxic. They filed it in the chart and didn't do anything about it. So for those of you that know anything about digoxin, the classic long-term side effects or things that are exhibited with dig toxicity are depression, weight loss, and hallucinations, delusion type things. So what truly ended up happening in this particular case is we had several meds on board for the heart failure. In this particular situation, her potassium was actually low, and they hadn't tried to correct that either. And when your potassium is low, you tend to exhibit more symptoms of dig toxicity. And what we ended up doing in this particular resident is the doc ended up de-seeing the digoxin, and then slowly we were able to remove all of the behavior medications, and they did drop the Zoloft down to 100. So we basically decreased the digoxin to DC. That gets rid of one medication. They did end up having to add some potassium. They DC'd the Haldol, they DC'd the Seroquel, they DC'd the Buspar, we DC'd the Ativan, they dropped the Zoloft to 100, and we DC'd the Remeron. So, I mean, pretty amazing case, but it's a really good case. Great question on the potassium level. You got that. But one of the biggest things that stood out to me here was the pharmacist, which was me, had come in and noticed the high dose of digoxin. For those of you that know I don't know if anybody knows what the Beers list is, but the Beers list is a list of medications that are potentially inappropriate for use in the elderly because of potential side effects and different things. Digoxin over 125 is considered a Beers drug. And obviously you need to be monitoring for the side effects on that. So we through a roundabout way, addressed her hallucinations and agitated type behaviors, her depression and weight loss by getting rid of digoxin. The other thing that I wanted to point out here too is you can see, for those of you that know any dosing on the psych medications, Haldol 0.5 BID is a pretty low starting dose. Seroquel 12.5 BID is a relatively low starting dose of the medication. The Buspar 5 BID is a relatively low starting dose. Zoloft, obviously 200 is a fairly high dose, and Remeron 7.5 is definitely more effective in stimulating appetite than a higher dose. But that's one of the common things too, is somebody starts a medication and instead of working up the dose to determine if that medication is effective, then they just end up adding something else. And they add it at a starting dose and they never taper it up, and we never know if it works. So this is a classic case of, a sprinkle of this and a sprinkle of that. And we really don't know, what was effective, but in this particular case, no medication would have been effective in treating the toxicity for digoxin. The other point too is one of the things I wanted to include is, I don't know if you guys are aware, but there is a kind of a newer regulation with regards to pharmacist recommendations and follow through. So we actually track acceptance rates for my team. And what that means is that the physician has actually responded to the comment. But you are supposed to have, in any long-term care facility, you are supposed to have a policy and procedure that kind of dictates a time frame as to if the primary physician has not followed up to the comment, then what your process will be as far as involving the medical director. They also included in there that your medical director gets a copy of all the comments, which isn't really the fix. The fix is to make sure that the comments have been addressed. Our usual thing is after 15 days, if it hasn't been addressed, then it goes to the medical director, because we definitely want a response in a more timely manner. There is something that's called time-sensitive comment, and if you include a time-sensitive comment, then under the Impact Act, theoretically, that's supposed to be handled by midnight of the following day that the facility is notified. So in the very least, you want to make sure that you have some sort of a policy to make sure that docs are following up on those pharmacist comments. And in that case, we probably would have got this at the very beginning, that first month that I asked for a digoxin level, and we never would have had to have the situation where they started adding behavior meds. Questions or comments on that? A lot of you picked out, delete Chandler Brown was the one that picked up on the Digoxin dose. Good job on that. Lots of psychoactive drugs. Somebody pointed out both Haldol and Seroquel together. That's definitely not a good combo. Those should have been definitely tapered up to determine if one was going to work and not add another one. I love the diet comment from Kelly. That's actually great. Being hangry is tough on all of us, and I agree. And the potassium level, that was something that was added as well. They were low in potassium. So great comments there. Any other comments that anybody has on this particular case, or any thoughts? Any questions at all?
Dave, this is Jessie. I have kind of a question piggybacking on what Lisa has to say. When we're looking at side effect monitoring, especially for an individual that we clearly have some polypharmacy going on, what angle should we take? What should the approach look like?
That's a good question. There really are a lot of, theoretically, when I'm reviewing each medication, I'm usually looking for, I always tell people, efficacy and safety. So I want to see if the drug's working, and I want to see safety monitoring. Now, we all know that if you look up, we call it the PPI, the package insert. That's like the gold standard, but I know a lot of you guys are doing informed consents. And if you do an informed consent for Haldol or the antipsychotics, and then you do an informed consent for the boost bar, you do an informed consent for the Ativan, and then the Zoloft and Remeron, you're going to have a list of like 20 different side effects, right? And typically what ends up happening is they're added to the MAR, and there's a little entry that says monitor for side effects for antipsychotic, and you have like 12 things listed. And then the nurse looks at the resident while they're passing meds and either puts a plus or a minus. I don't find that as a very effective monitoring tool, because I don't think they really take the time to review all 26 things in the 4 different lines to determine if they're having any of those things. But I think that, probably one of the best things that you can do is work with your pharmacist on monitoring some of the most frequent side effects, and not just from the medications, but maybe from the combination of those medications used together. Obviously falls are going to be very important. Confusion, sedation, there's several that you could really zero in on things that are going to raise a flag for me. But I think you just kind of have to work with your interdisciplinary team, your medical director, and your pharmacist to really care plan each of the individual residents for things that would be a red flag for them.
Thanks, Dave.
You bet. And feel free to ask any questions as we go along. I really wanted this to try and be kind of any questions that you have, any things that you see right away, anything that, you see something that you got a question on because you have a resident that is having these issues, just feel free to throw that right in the old chat box. Okay, we can move on to the next slide. I think we talked this one to death. So again, follow up on pharmacy comments is super important story there. Really starting doses, making sure that if a medication is added, that they really taper that medication up and ensure that it's either going to be successful or it's DC'd. We should never add something, realize that it might not be working, and then just add something else and leave that medication, because that happens quite a bit. And then looking at the resident obviously as a whole and trying to eliminate polypharmacy is super important there. Any other follow-up questions, comments on that one? All right. Okay. One person did have a question on if the DIG level was toxic, were there notes that the critical value was reviewed with the provider? No, there wasn't, even though no adjustment occurred. Just curious. Nope. There actually was not any documentation. The only thing that was on the lab sheet, it said noted, a date, and there was no initials. So we don't even know who actually noted it and put it in the chart. It was just, they just had noted, a date, and there was nothing in the notes at all, which was sad. And then somebody was asking about how to document to not do a GDR with a stable schizophrenic resident on Geodon. If you take a look at the regulations that have to do with GDRs, your schizophrenic residents, schizoaffective, bipolar, those are folks that we really don't want to mess with their antipsychotic medications. The only time that we would really kind of push for an actual reduction in a medication dose in that situation is if they're having side effects. And the side effects would have to be something, you kind of look at that risk versus benefit, and are the actual side effects something that is going to negatively impact the resident? When you are using a antipsychotic for dementia, you actually do have to try a taper in the first year. Like the 2 trials, you're supposed to do 2 trials in the first year, 30 days in between trials in 2 separate quarters. And if they have dementia, you actually are supposed to try an actual reduction and show that that fails to follow the regulations. With the other diagnoses like schizophrenia and bipolar and schizoaffective disorder and so on and so forth, those actually do not require a taper. So any sort of risk versus benefit assessment by a prescriber will work. And that will definitely cover you as far as a citation issue. And I'm definitely not a fan of tapering anybody that has a clinical psych diagnoses with messing with their medications. That's not a smart thing to do unless they are actually having side effects. Okay, let's go to the next one, unless anybody has any questions. Okay, so in this next one, we really wanted it to get at, I get the question a lot, and we have a resident that came in and they're on a lot of psych meds and we don't know why, and we don't know if we should taper them or not. That's a really common question that I always get. So I thought I'd write up a case. This isn't an actual case, but I think it's typical in just about any facility across the country where they come in, they're on a bunch of meds, and you don't really know where to go or where to start. So we'll get to the diagnoses here. Okay, so 78-year-old female, new admission to the community. Primary diagnoses were dementia and history of anxiety and depression, as well as high blood pressure. Of note, she did come from an assisted living, and they were no longer able to control her behaviors. And they needed to get her in a skilled setting where it was more appropriate to control her behaviors. So transmitted to your facility. We're going to kind of work through this one together. Next slide. Yeah, get in your typing shoes and get ready to start typing, because I got some questions here for you. One, does anybody see anything that kind of stands out at all? You guys had some really good finds on the last one. So let's see if you guys can tease out anything that's bugging you when you first look at this. Okay, here we go. So many psych meds. Yes. Good one. Benzoduplication. Yes. Venlafaxine can mess with hypertension. Yes. You guys are awesome. Peggy Trestle is on. Hi, Peggy. 3 antidepressants. Yes.
Hi, Dave.
Good to see you. Antidepressant triplication. Yes. Lots of antidepressants. Too many psych meds. Also Xanax contraindication. Does anybody notice something like from the last case? Namenda and Aricept. Yep. I want you to take a look at the doses and see if anything bothers you. Tylenol, actually, she wasn't using any Tylenol, so pain was not an issue in this resident that I made up. Anybody? I want somebody to guess it right. You guys nailed the last one. I can't believe somebody got the Digoxin right away. That was awesome. Layers. Okay, so one of the things, and I purposely included this because I really wanted to drive. Oh, good one. Catazina. Clonidine can cause sadness. I think you might have mistyped on that one. Somebody got the clonidine. Good job on that one. Sedation. Good. Okay, so one of the things, lower dose of, yes, Kyla got it. Lower dose of the Zoloft. So this is one of the things that you're probably going to have your pharmacy get involved with this as well, or your pharmacist, so you can kind of learn some of these things. But as you look through a lot of these medications, they're all at starting doses again. Aricept 5, usually it's 5 milligrams for 5 weeks, and then 10 as long as they have activities of daily living, unless they have kidney function issues. Namenda 5 daily. I don't even see Namenda 5 daily. It's usually 5 BID for so long, and then they're supposed to taper up to a certain dose to minimize side effects, but 5 daily is not going to do anything. Seroquel 12.5, again, that's a starting dose. Xanax 0.25 BID is kind of a starting dose. And then why would they add Ativan as a PRN? That doesn't even make any sense. And to give you guys an idea, I always like to, yep, you can type her up to Namenda ER, yep, for the 28 daily. One of the things that I always explain to people that are kind of naive or don't know a lot about medication stuff. So the benzodiazepines, which are like lorazepam and Xanax, those are just like alcohol. They do the exact same thing. So alcohol is actually a benzodiazepine agonist. So when I explain like what the different meds are, I mean, you guys have all heard of Valium, right? The hip thing in the 60s and 70s used to be Prozac and Valium. So Valium, I always relate all these medications to alcohol. So the only difference in all these medications are half-lives. And so I describe like Xanax and Halcyon as like 1 shot of tequila because I love tequila. Lorazepam is like 2 or 3 shots of tequila. Clonidine is like 4 or 5 shots of tequila, and Valium's like 7 or 8 shots of tequila. So it's all in half-lives, right? So it would be really strange to me that they would be using a short acting as a scheduled dose and then a longer acting for the PRN. Combined with the fact that benzodiazepines are on the Beers list for use in the elderly, so they really don't tolerate them very well. Not a very good choice, obviously, for anxiety in this situation. Starting doses of all the other medications, somebody picked up on venlafaxine can cause issues with hypertension, which is a great point. But again, starting doses for all of this stuff, and what they typically do is they're going to come in on these medications, they start exhibiting a symptom, the physician gets a fax that says, hey, this resident is exhibiting this. What do you want to do? And the doc says, start this. It's never, here's the entire medication list. What could potentially be causing the situation? Whoever picked up on the clonidine, that was a great one, because clonidine also is on the Beers list and shouldn't be used in the elderly. And typically what ends up happening is you don't really see people starting on the clonidine patch until it's kind of like a last ditch effort. So usually if I see a clonidine patch, then I should see lisinopril 40 twice a day. I should see Norvasc, 10 daily. And I should see like metoprolol ER 100 daily or something like that to qualify to go to the last ditch effort of the clonidine patch. So in this case, really, somebody actually doing an astute review on this resident could really take a look at the blood pressures. And in this individual case, we're going to say the blood pressures are low, so meaning that they really don't need the clonidine. And the best avenue in this situation isn't even touching any of the psych meds. It would be removing the clonidine patch. That would resolve the low blood pressures and the potential confusion and issues with clonidine. And then we could monitor blood pressures. And if the blood pressures did increase, then we could maximize one of these medications, probably DC, the calcium channel blocker, get rid of the Norvasc and just keep the ACE inhibitor. And there you're getting rid of two medications right away, resolving the blood pressure issue. And most likely in getting rid of the clonidine, you're also going to resolve the issues with the behavioral issues. I of course, go back to what I was saying before, which is there's a lot of polypharmacy here. And what I would do personally is I would do a stepwise approach to start eliminating medications and maximizing the doses of the medications that we need. So the Aricept and Namenda, those are disease modifying agents for dementia. They are effective, but they do have to be tapered up to the correct dose in order for them to be effective. What does it mean for those to be effective? Sometimes they will have a little help with controlling behaviors, but really the goal of those medications are to preserve function and slow down the gradual loss of cognition. So you're not going to be able to see a difference until you actually take them away, which you don't want to do. If you have somebody on Aricept for 5 years and you DC it, within a few days, they will drop down to the level of cognition they would have had if they never had taken the medication, and you never get that back. So as long as they have activities of daily living, I do not recommend DCing the acetylcholinesterase inhibitors or the Namenda. So I would definitely taper those up to a reasonable dose based on kidney function, make sure that those are maximized. And then most likely we would probably be able to get rid of the venlafaxine. Most likely you're probably going to be able to get rid of the benzodiazepine, lorazepam, and Xanax, and then take a look at increasing the Zoloft to a reasonable dose, and most likely getting rid of the Seroquel as well. Really, you're going to be. It all goes down to safety and efficacy, and the main thing that I would be looking at in efficacy here is obviously the target behaviors that you've identified. and hopefully that you're monitoring on a shift-to-shift basis. And when I am making changes, I always recommend one change at a time. I don't like doing more than one change at a time because then you don't know what works and what doesn't work. But definitely taper off the clonidine would be my first step, and then kind of sift through all the medications after that. But most of the time, what ends up happening in these situations is they continue to exhibit some sort of behaviors, and either another medication is added or the psych meds are increased, which is the exact opposite of what we want to try and do in these situations. Okay, questions. I know I'm rattling off a ton of stuff. So does anybody have any questions or comments on that at all? Oh yeah, and don't forget to update your care plans as changes are made. That's super important. Agitation, go ahead.
Yep. Did you see Lisa's question?
I did. I was just gonna mention that. I don't really like using SNRIs in the elderly, to be honest. It's like you said. I mean, it can cause some hypertension issues and agitation. I try and stay away from those and try and stay with the SSRIs. But I do see a lot of venlafaxine used in younger population. But I don't like using a norepinephrine reuptake inhibitor in the elderly at all. Any other questions or comments? Does this bring out any questions in any of your particular residents that you had something that you wanted to always answer or you've always wondered about? Okay, I guess not. Okay, let's go to the next slide. So yeah, just to kind of wrap up that case, I really wanted to just basically hit really hard on the polypharmacy issue, really looking at starting an effective medication that's safe to use in the elderly. So the Beers list is super important, and that you maximize the dose. And if it's not working, make sure that you DC the dose. And really that's hard to do, but you need to make sure that as you're kind of working through these cases, that you keep a good documentation of what's been tried and what's been DC'd and what doses were used. Because I hear a lot of times, oh, we tried that and it didn't work. And I always say, okay, well, what did you actually try? I mean, did you throw a sprinkle of it and it didn't work and then you DC'd it? I mean, did we taper it up? Like, how did you do that? So making sure that you're really cognizant on the dosing and not having those starting doses stay on forever. I really encourage everybody to partner with their pharmacist, and I know, I'm kind of a huge proponent of pharmacists because that's what I do, but we are just part of the interdisciplinary team to help you. And one of the biggest assets that you can use us in is making sure that we're reviewing each resident as a whole resident instead of just particular issues to fix. Next slide, unless anybody has any questions. Okay, I'm going to turn it over to Jesse.
Thanks, Dave. I want to just comment too, when we look at kind of evaluating the resident as a whole, when we're seeing any kind of change in condition or have kind of a target on a medication, we want to make sure that we're sending over the whole picture to the pharmacist to review if we're asking for those interim medication regimen reviews. So, just a reminder that we're sending those whole lists over, the labs, the H&P, so that they can get as much of a picture of that resident as possible and help us in evaluation of that resident. I know sometimes we forget some of those components, and like Dave mentioned, it's super important that we're looking at the resident as a whole. So in review, we've reviewed looking at the patient individualized goals of that resident and individualized approach, and ultimately wanting to make sure that when we look at methods of side effect monitoring, that it's not a one size fits all, that we're really tailoring that approach by partnering with our pharmacist and looking at that individualized medication profile and individualized goals of that resident. And that loops us right back into the importance of communication with our pharmacist and the involvement of that pharmacist in our interdisciplinary team. So when we took that poll earlier in the presentation and had the opportunity to share what their involvement is with the pharmacist, this might be a time to reflect and engage that individual a little bit more. Behavior management alternatives. Again, this is an individualized approach, and when we partner with our pharmacist, the pharmacist can help us identify the goals and maximize the efficacy and dosing of the medications that are prescribed while minimizing those side effects. And that may play into looking at alternatives for behavior management. With that, oh, and there's a question in the chat there.
Yeah, and I can take that one. The question is, it seems like a lot of times the primary care provider does not look at the whole picture when getting these requests for changes in behavior. Have you seen any effective ways to better engage in these conversations? I think one of your biggest challenges, and my dad was actually a physician and he was a psychiatrist, and I got a lot of insight into the training that physicians get. But remember that a lot of these primary care providers that we're working with are general practitioners. They're not psych, they're not high on psych education. And they did one rotation in psych, and it's not in long-term care. It's in a primary, hospital acute psych setting. And what do we do in acute psych settings? We throw PRNs, we hit them with an IM, we get them stabilized, and we send them out. So that's what their comfort level is. They don't know any different. So one of the biggest ways that I've had to have an impact, and I've had a positive impact, is to try and have a behavior meeting with the prescriber. So the prescriber and the pharmacist can interact, and they can learn that, we can be trusted, and we do know ways to help with medication adjustments to be successful in long-term care. And it's completely different than the acute care setting. So, trying to help build that relationship with your primary providers, your medical director, and your pharmacist is super important. And for that one person that doesn't know the name of their pharmacist, that's kind of a red flag to where that person definitely doesn't have a good relationship with your providers. And that can be, some of the most positive things that you can do to have a positive outcome for your residents, for sure.
Good question, Kyla. Next slide, Mary. So again, we have an opportunity. If anyone else has any questions for our guest pharmacist, Dave, today.
Anything, you guys can ask anything. One thing I did want to say is number one, thank you very much to Jesse and the Mount Pacific team for asking me back. I really appreciate to be able to reach out and share, some things that I've learned through my 25 years of doing this. We were really, really happy to have, the amount of feedback that we've gotten in previous programs, and that really will kind of guide some of the future ones I think that they're going to be doing. So really, really appreciate it if you could just take a minute, fill out the feedback evaluation of the program, things you like, things you didn't like, and things that you'd like to hear about in the future. I'm actually engaged with the National Association of Directors of Nursing and going to be doing a lot of programs for them and speaking at their annual convention in Orlando. But we really want to hear, as we're coming out of this transition from COVID and lockdowns and things, you know, what kinds of things that you guys are having challenges with and how we can help you, whether it be through Mountain Pacific or the National Association of Directors of Nursing or whatever it may be. But really appreciate the evaluation and any feedback that you can give us so we can really help tailor our education to help all of you.
Thank you, Dave. And we are extremely grateful to have your partnership. And I think that this has been a worthwhile series, and we definitely look forward to future collaboration. And I love the engagement. Thank you, guys. It looks like, let's see if there's some more questions in here.
Yeah, we do have a couple. Do you think a pharm consult should be a part of a protocol for any patient resident that is experiencing behavioral issues, even with a dementia diagnosis prior to transfer to higher level of care? Yes, I love that. Around memory care most of the time. So yes, and I mean, whether it be a pharmacist or a psychiatrist or a primary provider that understands behavioral issues, but I've found in a lot of situations that if you change approach, you can change the trigger and you can change the behavior. And really what you have to do is you have to focus on that trigger and figure out, you know, what is triggering that resident and what you can do differently to change the outcome or the behavior. And I'll give you a really easy one that I remember from a training program I did with CMS. It was a web series that they had, and they were trying to explain the different levels in between G and IJs and different scenarios. And they had this one case that stuck in me forever. And it was a resident that was an elderly resident with dementia, and this was in a nursing home setting, so a little bit different than an assisted living. But it stuck with me because the whole situation came around showering, and we all know that you know, showering in the elderly is a hard thing. Especially with dementia. You have folks that, I mean, you know, you have folks that go through their life showering and they don't have somebody else in there with them. And then all of a sudden they have dementia and somebody's taking off their clothes and taking them in a shower room, right? So in this particular facility, they were, she wasn't showering. They ended up giving her Ativan prior to showers to basically calm her down so she would get in the shower, and she was still, you know, grossly having terrible behaviors. And so, you know, the state came in and they didn't like the Ativan. They started doing some research with the family. And it ended up coming down to the fact that she had some terrible history of being raped in the shower. Nobody knew that. The family knew that. And what they really needed to do is find out some very good history on this resident and things that could potentially trigger this resident and things to avoid. And obviously, if there's some sort of an event like that, showering's out of the picture, right? So they recommended doing sponge baths and doing different things to alleviate the trigger, which was trying to get her into a situation that was a terrible, you know, frightening memory for her. But that goes a lot to, you know, identifying the trigger and reviewing what kind of non-pharmacological things that you can do to alleviate that trigger from occurring. Then somebody's asking, resident with BPSD, which is behavior, psychological symptoms of dementia, and combative, non-pharm approaches are not working. What is a good med that may help? So that's a great question. I love that question. It's a general question, but I love it because it's something that I use with my team to train them. If you have a resident that has that has hallucinations or delusions that are troubling to them, that is the situation where an antipsychotic is appropriate. So again, if you have a resident that is hallucinating or delusional, and if it's delirium, that's rapid onset, that's probably a medical issue. If it's a slow gradual onset and it's hallucinations, delusions, then an antipsychotic is appropriate. And we would choose an appropriate antipsychotic. We would do a starting dose and taper up. And we would make sure that, that medication is going to work. And if not, we try something else. If you have any other situation where you're dealing with behavioral type issues that are not hallucinations and delusions, then the first thing we would look at is we would look at the resident as a whole. Is there anything on there that we could potentially get rid of that could be causing it? And if there isn't, then your best medication to control those behaviors are going to be a mood stabilizer. What are mood stabilizers? They're classic bipolar/seizure drugs. And my personal choice is always Depakote. Any of the mood stabilizers will work. The reason that I choose Depakote is because Depakote has a very wide therapeutic index, which means there's a lot of different, doses you can use without it being toxic. It doesn't have very many side effects. It's available in sprinkles and a liquid. It doesn't have many drug interactions. So I typically choose Depakote, and that's what I do. She said, so not delirium, tried Seroquel, which is sedating. She couldn't even walk. We did try Depakote. SSRIs are definitely a good option as well. We do use SSRIs for anxiety and those types of issues. But my question would be, did you use Depakote? Did you taper up the dose? Usually with Depakote, you're going to start at 125 twice a day. You'd evaluate the behaviors after 3 to 5 days. If they're still having behaviors, you go up by 125 BID. So you go to 375 twice a day for 3 to 5 days, review again, still having behaviors, you go up to 500 BID, and so on and so forth. You keep escalating every 3 to 5 days by 125 BID. Let's see, lots of good questions. I do like the triggering comment. We always want to find out what's triggering the behaviors. I would like to see what the combative behaviors were, but I would probably use Depakote, and I would wonder if the dose was actually tapered up and maximized, and then once you, because I honestly have only seen a few residents that Depakote wasn't successful in for verbal or physical agitation. So be interested to hear about that. Definitely need striking out at others, yells in the hall, believes someone hurting a child. So there again, you get to potential hallucinations, and you might look at. You could theoretically look at another antipsychotic. Seroquel is probably the most sedating, so you definitely could possibly look at another one. But that's a great case to discuss in an interdisciplinary team format with your pharmacist and physician and see what you can do. But again, it's tough to come up with a recommendation without seeing the specific behaviors and going through that whole process. I think we got them all. Oh, you have Dave from Omnicare and Billings. We'll chat with him. That's awesome. Dave's actually somebody that works for me. He's an amazing consultant pharmacist, and I trained him, and I think he's probably better than I am. So really encourage you to reach out to Dave and kind of talk that through him, through those issues with him. I'll let him know, Elena, that you and I had a chat, on this program, and that you'll be reaching out to him. But Dave's a fantastic pharmacist, and he just happens to have the same name.
He is great. Dave, did you see the question from Lisa about, let's see, monitor for hyperammonia, ammonia?
Yeah. I mean, we typically do, like, we have certain labs that we do. You have to monitor for thrombocytopenia and ammonia issues and LFTs. I haven't seen a lot of it. I have seen some thrombocytopenia occasionally, but you definitely won't want to do labs. I mean, that's a standard for any medication that is going to cause particular issues. You got to monitor for potential side effects.
Thank you. Thank you everyone for the engagement and the conversation and the participation. I hope this was a valuable session for everybody. And I sent a link in the chat that had an updated beers list, and I was able to open it, but let me see if I can follow up on that. And when we send this recording and resources out, we'll go ahead and attach a PDF of the beers list as well. So kind of stay tuned for that. Next slide. And we'll include these resource links. And again, we thank our guest speaker. Dave, thank you for answering the questions. We had some wonderful questions, and we certainly look forward to future collaboration. I feel like I have lots of notes in front of me and some resources I can follow up on and help support our community. So thank you, everyone.
Yeah, thanks again, and thanks for having me. And again, we really appreciate any feedback that you have on this program and any programs you'd like to see in the future. You know, it may not be me, it may be another guest, but we'll certainly help us know what kind of education everybody wants. Have a wonderful day, everybody.
Thank you, everyone.
Thank you.